Kelly, thank you very much for gracing me with your presence here online. I greatly appreciate it. We got a lot of stuff to talk about. So just take a quick second. I'm sure everybody knows who you are, but tell them who you are and what it is that you do.
That's a good question. Existentially right now, what are we about? I'm getting some double feedback here. Hang on, I'm going to lose one of these. I'm a physical therapist and a strength coach, and probably not in that order. And and I should actually say I'm probably more closely aligned with physiotherapy, not our traditional physical therapy, how we think about managed care. A little bit different. I think, I've owned a gym for the last 15 years. It just closed because of COVID, but I was a professional athlete, ran a gym, became a physio, and really have spent the last part of 15 plus years trying to figure out why there was such a big gap between what we were talking about with human performance and how we trained athletes and managed adaptation with how our traditional medicine was set up and even structured. My father's a physician. My grandfather's a physician. I grew up around, doctors. I understood that. I made it was a conscious choice not to go to med school. And yet I ended up sort of in this vacuum between, hey man, there's a big gap between people who are really, not very fit, really detrained, just need some movement to get out of pain, which is how we're treating people in physical therapy. And hey, how do we take what we're learning with this incredible, skill set as physios and physicians and all of the sort of the group that we can all work together and say, hey, here's what's human potential. And then how do we begin to sort of say, well, if this is our best practice at Formula One performance, how do we take those lessons and actually apply them to greater populations so that sport isn't just, circus, because sport is great, but it's, we can, E.O. Wilson said it best. He said, that the highest calling of science is to serve the humanity. So, sorry, I'm trying to balance here. So the short is, I want to take these Formula One lessons and apply them backwards. And that means we have to be spun up in environmental considerations, environmental constraints. We're going to have to understand people. We're going to have to understand nutrition. We're going to have to movement quality. We're going to understand genetics. It's a complicated thing. I mean, you're a physician, and you can appreciate that the human body and the human being is the most sophisticated structure in the known universe. So let's start there. Then let's try to untangle, pull at the cords of saying, how do we keep people durable and pain-free, maybe, or at least functional and happy until they're 110. And that, I think is a worthy life's work, and that's sort of what I'm working on. I don't know if I'm doing a good job. I mean, I think I give us all like a D+ right now. I mean, we haven't moved the needle on back pain or ACL injuries for children or, oh my gosh, so we're getting started, but what's happening with the internet and even the relationships, the example that you and I are having is it's so much easier to create a loose network of power where we can magnify what we think is best practice and begin to speak to people where they are.
Yes. And, it's interesting. I love what you said about F1, Formula One, because I often say to people, like, what we do with professional athletes, all of that stuff is applicable to even like the little old biddy who had a hip fracture. We just need to take it and scale it down to her. Right. And so from my point of view, every single patient is a professional athlete. Their sport might be different. Some might be playing professional NBA basketball. Some may be playing, picking up their grandkids and carrying their groceries. I don't care. I'm going to make you the best at whatever it is your professional sport is using the tools that we have. And when you consider, if you look at your average car today, right, and you look at all the performance and the safety features that are from that car, where did they come from, man? They came from NASCAR, F1, or whatever. And then they trickle down, they changed them a little bit, brought them down to the consumer level, and that's what they gave them. And I think that looking at fitness, looking at wellness, looking at mobility in that light is in my opinion, and in your opinion, I think, the ideal way to look at it.
I would agree. And, what I would say is, we have confused, or I would say my profession largely has even skated by on the fact that humans are so durable. we are healing machines. We are durable. And so what we've said to a lot of people, especially the way reimbursement is set up, is saying that, like, look, it probably doesn't matter how you move for a while. You can, and especially at low speeds, at low loads, right? I mean, you can just get away. You can smoke some cigarettes, eat a little chocolate donut, and do whatever you want. But that does not speak to the power and potential of your physiology. And it's difficult. There are difficult bells to unring when you're 60 and you fall and your bone density is terrible, right? Because no one said you have to load, or you've gone through that lateral compartment or medial compartment, or you've herniated a whole bunch of discs because you haven't loaded the discs and you're not fluent. So what we always do is say, hey, look, you may not need this, but we want you to have full access to your physiology. So yeah, you may say, I don't need my full hip range of motion. We're like, well, you're going to need to get up and down off the ground someday by yourself. In fact, the number one reason you're going to end up in a nursing home is that you can't get up and down off the ground. And so maybe that hip range of motion, that ankle range of motion, the strength to be able to push up from the chair, that's something we shouldn't just wait around until we hit the minimum thresholds. And in fact, when we begin to look at it the way you're talking about, but saying here are our best practices, that's something we're teaching to the best expression of the human physiology. These are the positions in which you can generate the most force. These are the positions in which you're most ground force tolerant. These are the positions that allow you to take the breath and maintain your breathing and manage your neural dynamics. You don't have to. It's a choice. And clearly you don't have to have the best expression. But it's a specious argument to say what you're doing is good enough. Because what we're really saying is I don't get paid to help you reclaim your total function. Mm-hmm. And maybe the medical system is honestly not the place to do that. So it opens up a whole can of worms about saying, well, where do we teach people to move and to eat and to sleep and to manage all those things? Look, from a perspective, when you and I went to high school, the chance of us being diabetic was 1 in 4,000. Chances of us being our kids being diabetic, independent of the color of our skin or how much money their parents make, is 1 in 4. And if you're an African-American woman, it's 2 out of 3. If you're a Latino male, it's 2 out of 3. So what we're seeing is that there's a big mismatch right now between environment and organism, and it's not anyone's fault. You come from a place, you come from the system. But I really do believe, and I know you know this and believe this, your joints are designed to last 110 years. Trauma is going to happen, but you have the raw materials to make it the distance.
Mm-hmm. Mm-hmm. All right. So speaking of joint, so first of all, I'm going to come to that, but there's 2 questions first we got to talk about. So number 1, strength training is a major part of the way that you live your life on a day-to-day basis. So first of all, tell us why the love of strength training and why is this an integral part of what you do and teach to people? And you touched on it a little bit, but let's go a little bit more into that.
Well, I think if we pan back and just say, what are the conditions in which human beings came to be? There's some truisms. You have to sleep. You need to eat whole foods. You need to feel loved and supported.
Eat, sleep, move, baby.
Unfortunately, I can't get rich teaching you to eat, sleep, and right. I mean, move. I mean, it is the very truth. We used to walk 6 to 8 miles a day, just doing our business, and it turns out through the evolution of the human being, right? This is not, pining for the old Paleolithic days. That's not what I'm talking about. Your lymphatic system is an example. That's the sewage system of your body. It's how we decongest, how we take waste proteins and recycle them. That's the system. It's bootstrapped on your movement system. Like, how clever is the design to put your waste system right into your movement system? Because you're going to be moving all day long, getting up and down, sleeping on the ground, toilet on the ground, moving, walking, foraging, carrying resources. Turns out that if you don't move then as a modern person, and you're hitting that 2,000 steps instead of 6,000 to 15,000 steps, then doing a good job decongesting. Look at your tissues. So all of a sudden you're like, oh, okay, well, what's this concept of mechanotransduction? Which means you have to load some of your tissues in order for them to actually be the tissues they were differentiated to be. So if you want a strong tendon, that tendon has to eccentrically load, isometrically load, and concentrically load. And unless those conditions are met across a range of motion, you don't have a tendon. You have a subtendon, which is such a remarkable design that you can get by for a long time, right? You can turn your feet out and bunionize your toe and collapse your arch and put on crazy soft shoes, and someday you can get away with it and maybe you can't, right? Depending on if you hit the genetic lottery. So what I think about strength training is it's not just no machines at the gym. Like, what we said in the 70s and 80s was just, or maybe 80s particularly, was just do a contraction. A muscle contraction will take care of it all. But that doesn't speak to the coordination or the motor learning or motor skill of the human. And so I think strength training, and we put it in that system, is not just about having bigger muscles. It's about teaching coordination. It's about restoration of position mechanics. And suddenly you're like, oh, you mean a physical practice? I'm like, okay, Pilates plus some heavy kettlebell swings. Got it. Right? You do yoga and you deadlift and run. Got it. Like, I don't care what the amalgam is, but you either are exposing the body to the shapes and positions it needs to under load, or you're not. And what we're finding is, hey, we can argue about how much you need. You need to squat 3 times a week or 5 times a week or once a week. We can have that conversation. That's fine. Who's got the best secret scroll program? We can have that conversation too. But what we're finding out now is, man, if you're worried about your bone density in your 50s, that's a little late. You put on a lot of this mass early.
Yep.
Teaching someone coordination and restoring balance and vestibular and integration, man, I don't want to begin this conversation when you're 65 or 70. It should be rote, because you grew up in an environment that said, hey, this is what it takes to have social justice. This is what it takes to have national security, and this is what it takes to have healthy, durable people.
Yep.
And so I don't care what it looks like, but it's not optional anymore.
No, for sure, man. And particularly, I'm in Canada, so we have socialized medicine. Nobody pays for that, right? Or we pay for it, but through our taxes. And in the U.S., you guys have privatized medicine, and so it's important, man, and it should not be optional. I think people come into our gym, and I say everybody lift all the time, right? I don't care how old you are, man. If you're 72, I'm 75, whatever. We're going to scale the exercise appropriately, but we are still going to put you under a barbell or have you doing heavy farmer's carry or whatever. Like, because as you said, if you think about it at that time, it's already too late. You need to be doing this have this as a lifelong practice, right? You need to be doing resistance training.
What's extraordinary about that is that you are a physician. Now, as I said before we started, my father's a physician, my grandfather's a physician. You have a gym. I see what your gym looks like. I see your practice in there. And, one of the things that one of my friends, Mark Verstegen of Exos, did a remarkable thing where he moved the squat rack next to the treatment table in his original facility, so that people began to see that there was no difference between improving a position or restoring a mechanic or solving a problem. Look, you're going to twist your ankle. You're going to tear your ACL playing soccer. You're going to get into a car accident. You're going to take your eye off the ball a little bit. But suddenly when we begin to see that a movement practice, a loaded movement practice, is the same thing as preventing or restoring your hip range of motion based on the fact that you had, you were born dysplastic as a kid. It doesn't matter what's going on. We want to integrate these things. And I can't tell who the coach is. I can't tell who the physician is. I can't tell who the physical therapist is. They all look the same, and they're all speaking the same language. And as soon as we dis-silo and start to see that, I'm with you. And what you said was really important. And something that really speaks to me is I, for example, am not a big fan of corrective exercise. And it doesn't mean it doesn't work. Of course it works. But really corrective exercise for me, I'm not throwing shade at anyone, is basically tempo movement. It's slowing down. It's giving people a chance to feel. It's restoring positions. Or it's sort of very joint-centric or tissue-specific. I tend to use scaled versions of strength and conditioning. So I feel like I've taught on every continent except Antarctica, and if I say push-up, 100% of the world knows what I mean when I say push-up, right? And I can then scale that push-up in 1,000 different ways. Push up on the wall, lay on the ground, floor press, beginning of the Turkish get-up, right? We can pull in that position in row. We can push from that position in bench. We can dip. There's a million ways to express that extension of the shoulder. But what we like to do is use, as you said, scaled versions, appropriate versions of the movement language we're going to use for strength and conditioning and performance anyway. So what ends up happening is that our athletes who are training after injury or training after surgery already speak the movement language because it's their language. And that my elderly people are suddenly, my masters athletes, are doing the same scale versions of the things that my Olympians are doing. Except instead of heavy front squats, they've got a kettlebell and a goblet squat squatting to a high box to protect their range under tempo. But it is the same shape, same movement. And then what ends up happening is I really feel like, boy, my kids can front squat and swing a kettlebell and press and jump and land. Then we've created a movement lexicon that is dynamic, that everyone speaks to, that we have a universal diagnostic language, and now we're off to the races.
Yes, exactly. And you know, it's interesting. I believe that you talk about the lexicon. For me, the movements are all just the same way as a child. First you learn phonemes, right? Then you learn letters, right? And then you start to put those letters together into consonants, into words, and then phrases, and then sentences, and then conversation. So the movement, these are all just phonemes and words, right?
Yes.
And when you look at somebody, say, for example, Michael Jordan played basketball. He spoke the language of basketball like Shakespeare because he had the widest range of phonemes and the widest range of words, and he could string them together in the most eloquent fashion, right? You look to, like, name somebody like Ronaldinho, whatever, from soccer. All of them speak their language with a specific level, a certain level of grace and eloquence, right? But that is because they have learned all of these, like the small subset of fundamental movements, right? And then they've been able to express those movements in different ways to show it's like, no, not only have I seen this movement before, I know this position and I can express it in 15 different ways.
And what's crucial about saying that is we want to start to ask the greater conversation. Why don't you speak this language? Absolutely, your spine is designed to flex.
Yes.
But loading your spine under flexion is not the best expression of moving fast, maintaining position, maintaining length tension relationship, handling shear force. Of course you can do it. But I want that to be a choice, not your only choice, not your default, right? And if you're missing your hip flexion, you can't bend over, then what I'm seeing is, hey, we've just lopped off 50% of your vocabulary. You're still going to be able to communicate, but it's not in the fullest expression of the human being. And again, coming back to that place about how do we introduce play? Where do these movement fundamentals learn? Because what we're finding, and as you know, the people who are coming to you, their tractor trailer is on fire, and they've driven it down a blind alley, and they're like, "Doctor, help me!" And you're like, "Okay, step one, let's put out the fire. Step two,
did you even learn how to back this thing up?"
Dude, and you're like, "What do you mean you don't know how to squat?" Well, someone said it didn't matter how I squatted, right?
Yeah.
Right. And so all of a sudden you're like, "Well, okay." So what we see, of course, and I really try to appreciate that everyone comes from some place, is going someplace. And so when someone hasn't been exposed, then the burden is to have to reconstitute a lot around that. And so again, what I want to be shifting this greater conversation to is how do we create more durable people? And look, if you sit on the ground, toilet on the ground, sleep on the ground, get up and down, play, then we don't have to do a lot of formal movement training. We're going to teach you to front squat. We're going to teach you to jump and land a little differently, making sure, then we're just talking about turning up dials and increasing your movement language. But a lot of times I have conversations with people. I'm like, hey, look, I appreciate that you feel like this is the only way you can squat, but you're missing 100% of your dorsiflexion of your ankle. You have no internal rotation of your hip. Your quads are brutally stiff. And what I want to appreciate is that you're solving a problem with 50% of the working solution. So let's at least establish what every human being should be able to do. And you and I already speak that language. How much hip range of motion should you have? We agree. How much ankle range of motion should you have? We agree, because actually it was your field that established these normative ranges. And it turns out that those normative ranges are couched automatically in the normal expressions of human movement, i.e. squatting to the ground, i.e. hinging over, sitting on the ground in a long sit. Those positions and mechanics are buried in. If you can do a pistol, I don't ever need to screen your dorsiflexion. You know what I mean? And by pistol, I mean lower yourself down off a high object. I mean, that's what I'm talking about. So when we start to say, here are some movement minimums, let's keep an eye on that. Let's create a movement vital sign language that everyone starts to understand. You don't have to noodle on it and obsess on it every day, but every once in a while you're like, whoa, 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 I just got super stiff. I have a baby, took a red eye, just ran a half marathon, right? All of a sudden I'm like, oh, my blood pressure's high, my cholesterol's out of whack, I can come back. But we have said to everyone for generations, how you move doesn't matter. And you know, because you're in there putting out fires every day, I think you can get away with a lot if you're blessed with genetics, but you're going to be more durable if you move to the expression of how humans move to generate the most force, wattage, poundage, etc., which comes back to the gym again.
Exactly. I love it. Okay, so let me ask you now. You're a physiotherapist, strength training coach,
Oh,
you're a
man.
mobility specialist, and you are the author of the Supple Leopard. So why did you need a knee replacement?
Well, I like to say resurfacing. Doesn't that sound a little bit better? Like I still have my knee, but it's like I just put some new wallpaper on it. So this is such a good question because it really does confuse people a little bit. Like, hey, last year I ran a half marathon. It's 15 months ago. Last year I deadlifted 605, right? Last year I did a bunch of other kind of fun things. But what you didn't see was that I had to stop paddling stand up in my traditional stance. I had to go to goofy. That playing frisbee on the beach would make my knee swell. That my mountain biking made my knee feel full and get some swelling after that. You didn't see me squat for the last 7 years. You saw me hinge a lot, but you didn't see me squat. So unloaded, yeah, sure, I can squat down, air squat. Put a little load, a little speed on that. Get into a lunge position with my knee. So it turns out you can't out-mobilize. You can't out-strengthen fundamental trauma to the joint. And 7 years ago, I was skiing very fast, booted out, and ended up having an impact between my femur and my tibia, which imploded my meniscus, and I had 2 gigantic chondral defects and bone lesions. Mm-hmm. So when I went and finally got the MRI after like 2 months of constant swelling, and I said, the physician said, hey, in the next month, let's book your knee replacement. And I said, hang on, let's look at my function. Because I agree, I appreciate what you're saying is the inevitability is that I can't get around this. There's no meniscus transplant, there's no Oates procedure, there's no way that stem cells are going to magically go in and rebuild my knee, right? I'd love it if that happened, but we're not quite there yet with the technology, right? My bioadhesive bandage, magic thinking thing isn't going to work. But what I found was if I maintained my joint range of motion, if I kept my strength and made sure that my mechanics were as optimized and centrated through the joint, I could get away with a lot. And what I started doing was pulling certain movements which didn't tolerate very well. And I'll say, when I say didn't tolerate, I don't mean hurt. I'll say didn't feel good, felt whingy, felt weak, felt grindy, right? So I would just avoid those positions. And because I speak this language of the gym, I didn't have 150 movements I could train. I had 80 movements I could train. So I just continued to train those things. But it turns out eventually the reason I got surgery, I usually tell people a couple things. One, I think you're going to need surgery for these reasons. We cannot get you out of pain. We have tried everything we know to manage this. We've changed your diet, lifestyle, nutrition, mechanics, restored your positions, right? We've rested, we've used H-Wave, we've thrown the book at it, we've crossed everything off the list. And what I'm left with is, herniated disc. That's super irritable. And your brain sometimes is going to prioritize that sensitization, and we're not going to get ahead of that, right? My wife was born with dysplasia, and she managed that hip dysfunction by having big, strong glutes for a long time until she had both her hips replaced because she had terrible internal rotation and hip pain walking to school. Walking our kid to school gave her like 8 out of 10 hip pain. I was like, I think you're a candidate for total hip replacement. And it doesn't matter what you do or don't do. I mean, you could do some water aerobics and then not use your legs, right? But for me, it wasn't about pain. It was about my loss of my role in society. It was about my loss of my role in play and education and work, which is really important because that's the highest expression. According to the Said-Nagy model of disability, what we're looking at is not the tissue level problem. Like I trashed my knee. I'll use that word because it was definitively pretty beat up there. And the physician at Kaiser was like, "Oh, this is one of the worst knees I've ever seen." I was like, great thing to tell me. Thank you. What I tell myself, I'm like, you have a ball of white light in there, and it's a little dimmer than the other knee, but it's still a beautiful ball of white light. Let's go find out what we can do, right? And, so it wasn't about the tissues, and it wasn't about the ways I was compensating. It wasn't about the changes in my EDLs. It was about my occupying my role. And for me, I was starting to lose so much expression of the function based on the significant trauma to the joint. And on our Instagram, I have a little video called Lessons from Surgery, where my best friend is the surgical rep of DePuy. And so he's in there taking photos and in there. So I know what's going on, but I walk you through the trauma in my joint. And when they opened up the joint, there was some talk, was I a candidate for a hemi arthroplasty, just doing the lateral compartment. And when they opened it up, the amount of trauma on the trochlea between my patella and my knee, because the knee had been swollen for 7 years, and it basically just destroyed the articular surfaces. So the trauma to the joint, both the femur and the tibia, the plateau, the fact that I had no meniscus, and so the trauma, they were like, how is he didn't have any pain? Mm-hmm. How did you have this function? Well, I was like, well, I'm big and strong. I move well. I'm able to manage my symptoms by taking care of my range of motion. The joint didn't get too tight. I had terminal knee extension. I had full flexion. And I was able to buffer it a long time, which tells me that if I had more normative joint, right? People have the patina of wear and tear. That happens. But if I didn't have this trauma, that this practice of eating whole foods, of taking care of business, of walking and moving, allowed me to be as durable as I was. And that's really the case. But sometimes it comes down to, I don't care who you are or how magic you think you profess, you need a surgeon. And in this situation, the only good choice I had was a total knee resurfacing.
Yes. Yeah. And, it's funny, like I say to people quite often that studies show that even in the face of osteoarthritis, if you are working on your movement, your mobility, your strength, you're going to have better function regardless of the fact that you have osteoarthritis. And, like you, I'm an ex-athlete, and I've had 6 knee surgeries. So I know that I'm going to end up there, but it doesn't stop me from still trying to do my full depth squat, work on that, work on my Cossacks, work on my hip mobility, my knee, ankle mobility, because I know that the function is going to be better, right? And in the event that I need or when I need to have a knee arthroplasty, then my outcome will be better because my preoperative condition was better than it otherwise would have been. So I think that's so important.
The research, as you know better than me, because this is your domain, is that if you tear your ACL, you have a 50% more increased chance of having a total knee arthroplasty because of the chemical nature of what happens when you destroy that ACL. Just the rupture in there is really hard on the surfaces, right? Yep. Plus, then add in incomplete rehab, right? The fact that we never really get someone stable and going up again, or they train before the knee has stopped being, acute because they've got to get back to their high school soccer drama team, right? Whatever it is. So, I really appreciate what you're saying around, hey, it's not just the knee. Let's look upstream at the hip. Let's see how we can unload this and continue to give the brain as many movement choices as possible. Running at the end for me is I could not find a way to run where I could land correctly on the ball, but couldn't figure it out. It didn't hurt. I was just like, it doesn't work. It's like I'm landing on a pillow on one side and a spring on the other side. And, what I think was notable for me was that I really presented an interesting and difficult case because I'm 47 years old. I have these gigantic quads and decent function, no pain. And they're like, what do we do with you? And even when they came in and, cut my fascia looked very different. Mm-hmm. That the joint capsule just started to bleed. And they were like, what's going on? I was like, welcome to vascularization, right? They had a hard time cutting the bones because I've been under load for so long that my bone density was really hard, which is probably the reason I didn't, tear my leg apart when I booted out and crashed in the first place. And so what it makes me think is, wow, how difficult is it to perform really successful surgery with people without quads, no extensor mechanism, poor bone density, poor movement quality, poor general just, non-exercise activity tolerance, poor sleep, alcohol, nutrition. And I'm like, wow, the surgeons were asking our physicians to almost do magic, and then asking our rehab professionals who can see someone once a week, here's a handout, good luck on your knee.
Yeah.
I'm just suddenly discovering, I was like, oh, okay, we're not setting people up for success, right?
So tell me now, okay, so as a physiotherapist, right, obviously you have great understanding of rehabilitation techniques. So how has your understanding of those techniques, and then also your understanding of strength and conditioning training and mobility work, how has that affected your own personal rehab here?
Well, one of the things that we try to educate people on is, hey, look, you've got to understand some tissue healing times, first and foremost. What we tell people universally is there's no such thing as a fast healer. You either heal at the rate of human beings, or you heal slower than that. Right?
I love it when they say, I'm a fast healer, man. Like, okay.
Okay, Wolverine. So what I think happens has been shocking, is for me is this is the first injury I've ever had, real injury. I mean, I had a brachial plexus injury when I was paddling slalom. Just had to let that heal and chill. But, this is the first surgery I've ever had. And what I realize is that I have always hammered on decongestion, maintaining neuromuscular connection, pain management, those things, but I've never beat the drum hard enough. And so my physician, his job was done the second, the last suture was in, really, right? And if I waited the 3 weeks to see physio, and the only way I could manage my pain was through opiates and icing, I guarantee you I would have a hot, congested mess where I literally, at one point during the night, I was like, man, I can see why people have fasciopathies here. I can understand why they become addicted to pain meds, because if you give me one solution to manage my pain, and I'm just laying around waiting for this swelling cascade to just sort of, burn itself out. So it's funny because I woke up, I had a local spinal, and I woke up, and I was immediately, the first thing I did was flex my quadriceps. And I was like, oh, I still got it, and I'm going to stay on it. And I just was like, okay, stay connected. And the nurse was not pleased with me. My doctor did not, stitch me up and glue me. He just sutured me up so that I could express some blood and some fluid through the incision, which I appreciated. We don't need to trap all that in there. There's going to be a lot of stuff that needs to come out. And she was like, you need to quit flexing your leg. And I was like, over my dead body, I'm going to quit flexing my leg. Like, the rehab starts now. And so they wheeled me up, within 20 minutes, I'm stable, and they wheeled me up to my room. And I pulled out my H-Wave OTC, which is just an NMES device, neuromuscular electric stim device, put it on my quads, and just started pumping right away. Asked them for a hot compress, put it on my groin so I can start dumping lymphatics. Because early on, especially when I don't have to protect a tendon, I don't have to protect a ligament, I have to protect the capsular sutures, the internal sutures, right? I have to just heal the capsule and heal the tissues there, right? That's the thing I'm protecting. But that doesn't mean I actually have many, contraindications. It means that flexing my quadriceps is my number one goal, or dumping, congesting, because my tissues will not heal as fast. I cannot manage pain as effectively, right? I'm going to lose neuromuscular control if I'm horribly effused. And man, what you'll see is that I don't fight for terminal knee extension. I don't fight for flexion. I'm 6 weeks out today, and I'm doing something called Deadcember, where I deadlift every day. Mm-hmm. And you would see my function, and progressively loading, working on my range, respecting my positions, that is really, really simple to do on basically a progression. When I say deadlift, I'm talking about light loads. I'm not trying to get strong. I'm just saying, hey, I need to tell the tissues that in another 6 weeks, it's going to be time to giddy up when I hit 3 months. Yep. So that work starts the first day in the hospital. And so what I found was the rehab professionals have not done a good enough job insisting on being next to people to pick up the caseload. The surgeon is already on to the next case. She or he already has, it's not her job anymore. It has to be another gap where we overlap a little bit, where someone is pumping. I pumped and ran the NMES device 20 hours a day, 22 hours a day, right? So I got into a great fight with the resident because they gave me a wound vac, and I was like, oh, I love this. This wound vac is great tech. Unloads it. I barely have a scar on my incision, right? It's going to drain. I said, I get this. But I said, hey, this thing's going to be dry in 2 days. And he was like, no, it's not. You're going to leave it on. I was like, no. It's going to be dry. I will not be pumping out blood through this wound in 2 days. So what's the plan when I take it off? It's like, well, you leave it on for 14 days until the ready to see the physician. I was like, you don't understand. I'm not carrying this blood medallion around my neck when it's not, pulling anything out or unloading the suture. And he couldn't even wrap his head around why that was possible. And I made him understand that I would be bringing in a nurse, that when it was appropriate, I would call the office and then rebandage and clean up the incision. And that's not his fault. That is because we aren't doing a good job respecting the base physiology and then helping people to understand what they need to do. Like what I realized is I need to invent a pedal that shortens up so we can get people on their Pelotons, just doing some short little mini kid biking, because it is all about movement and whatever the scaled movement is down from the beast, right? We can protect your tissues. We can protect your load through speed. We have to do the healing, but managing the sleep, managing the pain, managing the swelling, that's my only job as a patient in the first couple weeks. And if I do that, I'm actually super aggressive, super outside the norm. And when I start to load this thing, AKA walk around, do my job, drive the car, that's the loading I'm talking about. I will be better prepared for that.
For sure. And, I wholeheartedly agree. I say it to patients all the time. I said, look, man, you and I are doing a group project at school. I am the lazy person, okay? Because I'm going to do 5% of the work, right? I'm going to do 5% of the work.
It's important. It's important work.
It's important work, but I'm still going to do 5%. I said the 95% is up to you and your therapist, man. You need to do that, and you can't avoid that. You got to put in the work, right? And I also agree with the early rehabilitation. They think I'm a Nazi, man, at the hospital, because it's like, oh, you got to get these people up right away. I want them up within 2 hours, and the nurses look at me, and everybody looks at me, and they're like, what are you talking about? I said, look, I want my people up, right? Wow. And if I could have, we haven't done it yet, but I've talked about it in our orthopedic department meetings. So look, if I can have a physiotherapist in the freaking PACU, so that the moment that dude has his feeling back from his spinal, you can get him up, get him moving, then that's the best thing, right? And I, I'm not a big, I don't, when I send people to physiotherapy, I don't use a lot of modalities, right? Because I'm more about working out, gym, and all that. But I do like what you said about the muscle stim and getting the quad going, because they also call me the extension Nazi, because I say, oh, look, this is the first thing. We need to get good quad function and extension back. And people can't wrap their head around how if you have good terminal extension, everything else is easier. People don't understand that. I'm like, but wait, how's that going to help me bend more? And I'm like, look, and I try to explain it in a way that they'll understand. But I said, look, trust me, get the legs straight, get your quads functioning, everything else will fall in line, right?
One of the things that I really appreciate and one of the, I'm so lucky that I get to work with so many bright minds. But one of the positions we work on, for example, is that leg just doesn't sit on the table and flex. If I lay down and you assess my range, you're only assessing my range in hip flexion. Turns out your knee actually goes behind your butt sometimes. It's called walking. It's called going downstairs, right? And if you don't respect the ability to have terminal knee extension, if you don't respect that anterior fascial line and that loading of the quadriceps and extension, and if you can't fully extend the leg, in long sitting, for example, where we normally assess that, then what you're going to see is that someone has terrible lunge pattern, terrible hip extension quad use, which means they don't have any control going down the stairs, which means that the leg atrophy will be through the roof because you actually can't load the upper quad unless that leg is in extension. And so what you'll start to see is that everyone perseverates, VMO, 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 a little flexion. But I'm like, hello, look at the rest of the leg and fascial systems. And so when we start to put our athletes on, so for example, what I mean is, here are your crutches. You're on your crutches. We're going to take your surgical leg, we're going to put it behind you, and we're going to make you start to weight bear the same way you would weight bear in bilateral or in a little bit of flexion. We're just starting to do isometrics and breathing and tempo work in a split position, which is how you're going to move through the environment. And what you'll see is that missing hip extension makes that tough. You don't have that full knee extension mechanism locked out, and if you don't have any quads to begin with, it's even harder. And what you see is that we get stuck in this little mid-range open pack position where we just don't have the kind of function we're back. So that, again, is a little bit along the line of who owns that? Where do we begin that conversation of saying these are the shapes you've got to be in? And by the way, that's lunge. That's stepping down off a box. That's pressing in a lunge. Split position. Those are the shapes of human function. This is why as a physician or as a strength coach, physician or PT or chiro, if you can't coach movement, you are a crappy physio coach. You're incomplete. I'm sure you're great, but your understanding of what's possible is actually a little limited. And fortunately, it's not very crazy. I'm not saying you need to be able to coach an Olympic lifter at the Olympics. I'm just saying that you need to know how to progress and how to regress basic movements. And so it's exactly right. And so what's interesting though is we can fight for that terminal knee extension we want, but if that joint is effused, if it's full of exudate, it's not going to extend. I'm just going to be pushing against a palatable patella, or whatever. So the idea here is if I can do my job as a rehab professional, or I'll say it, training, and I actually use the word training instead of rehab because I'm using the same sets of tools that we talked about in the beginning. How do I help my elite athletes recover from a stimulus of adaptation, sport, training, lifting, etc.? And it turns out I use the same sets of tools. So the same Normatec compression boot is the same thing that I'm going to use to help you manage. In fact, people are like, well, you're using Normatec? I'm like, well, didn't they put Normatec on you in the hospital? And they're like, oh, yeah, they did. They're squeezing my calves. I'm like, what do you think that's about? DVT? If you're pumping your calves, if you're pumping the leg, DVT risk goes down. Look at CRIPS, the complex visual pain syndrome starts to tank. Why? Because we're managing the vasculature. We're managing the lymphatics, which have been overwhelmed with trauma. So sometimes I'm like, man, the first principles, we're all like, yeah, first principles. And then I'm like, you didn't actually max out the first principles. So then we're just measuring type 1 errors after type 1 error, right? Mm-hmm. All we're doing is, continuing to measure poor management of the basics.
Yes. And, so right now I'm kind of working on a syllabus for a course that I want to give to new physios and trainers. And one of the things that I've been thinking about when, in developing this is, I think all physiotherapists should have their CSCS or the ACSM or they need to have this. And not only that, when I started thinking about it, I was thinking, shit, all orthopedic surgeons should have this because it's funny, I'm a gym rat and I've been a personal trainer. I've been a fitness instructor for before I started practice. I was that for 12 years, right? And so I have a little bit of a different mindset. And my colleagues, they kind of look at the stuff that I do and they're like, why are you doing this crazy stuff? But when I look at it now and I think this is how it should be. You should all have this understanding. You should never send someone to a physiotherapist and not have an understanding of what they should be doing and why they should be doing it and how they're doing it. You should be able to do that yourself. And the only reason you're sending it to these people is because you don't have the time, because you're a surgeon and you're better spending your time operating on people because that's what you're trained to do. But you should still have an understanding of this and know how it's supposed to work that way. So
the only thing that I can say is, look, you're a physician, I'm a physio, we can rail from the inside. But the thing that's really going to get people's attention is when we have better outcomes. So I'm like, let's put our money where our mouth is. I'm going to show you my outcome. Mm-hmm. And my physician, when I follow up next week at 6.5 weeks, is either going to be like, what the hell is going on? You can grab all the skin around my knee. It slides. You can grab the the scar moves just like my skin. I've got full extension. I've got my quads back. And you're going to literally, it does not look like, I saw a friend who hasn't seen me since the surgery. She's like, well, I can't see on your leg. And I'm like, I know, that's the point, right? Inside, I'm like, I'm never going to, in my own side, I'm like, I'll never use my leg again. This is my life now. But outside, the outcome of the subjective measures is that we've actually set some of our protocol benchmarks at the place of assuming people aren't going to manage their swelling. Mm-hmm. That they're not going to be loading or ambulating effectively. And my wife is like, Kel, I think you have, she's like, I'm not sure people have the discipline or the rigor to do what you've been doing. That's not here or there. That's not the reason not to say, here's what we're shooting for, right?
Right.
So to your point, one of the things I think Buckminster Fuller said is, look, you're never going to change the system from within by shouting at it. You have to propose a better model that makes the other one obsolete. And so suddenly when there's a cabal of physicians and outcomes and physios and coaches who are all on the same page, understand that it's not about getting back to full cleans faster than you can tolerate it. It's about how do we just max out the physiology, and that the human is so good, she will heal on her own remarkably if we don't mess it up. Those outcomes will be so telling and so remarkable that people will come and not want the last furthest thing, right?
Yeah.
Like, all of the athletes I know who need a hip replacement because they played in the NFL or did something, right? They all get an anterior hip replacement. Yeah. It's an anterior approach. Why? Because their outcomes are so much better, and their return to sport and life is so much better. They know now, and that's a great example of saying, hey, this is a better outcome. People will start to seek it out. It takes longer. My model in 2020 or 2019, I was like, the glacial pace is the breakneck pace. This is as fast as we can go to make change on systems that have been around for hundreds of years.
Yeah, it's funny, I kind of love it, but I kind of hate it. We at our facility, when patients come for physiotherapists, a lot of them come and says, "Oh, well, my physio told me to come here," and I'm like, "Well, if you were getting physio, why did they tell you to come to our place?" And it's like, well, they said they've done everything they could do, and now they come here, and it's like we get all the problem cases, right? But it's like, why? And because what we do works, right? And I'm not trying to say to people that our way is the only way.
No, not at all.
I'm trying to tell them that, look at, man, you need to. At the end of the day, it's all about movement, and as you said, it's about loading the tissue, taking them through appropriate range of motion. We have a range of motion there for a reason, so use it. We need to load the joints and load the muscles and load the tendons throughout the range of motion, not just through a quarter of the range of motion. Because when you walk outside and the black ice is there under the snow, it doesn't say, "Oh, hey Kelly, yo man, did you only do a quarter squat? Because then I'll only make you slip a quarter." It doesn't give a shit. It says, "Oh, look at there's Kelly. I'm gonna get him," and black ice, boom, down you go. It doesn't care. So you need to train the full range of motion. You need to assess all of that. So, that's important, man. It's important. You there?
I've still got here. I think my computer died on the other side. So we're going full
worry.
IG, and we'll get back into the other.
Yes,
you still hear me? Okay.
Yeah, I can hear you. So it's important to just do that.
The key here, and this is what I want people to continue to appreciate, is that the things we're talking about are still the basis of teaching of a movement practice, which could be expressed in Pilates or yoga or group fitness or kettlebells. We're agnostic about that. But what suddenly you've done when we have people looking at these components as a system, not as something to be done when I'm injured, not when I'm trying to play catch up, but this is part of my daily practice. Look, if you're walking a ton or have a mechanism to decongest, whatever that looks like, you want to swim? Great. You want to swim on a spin body? Great. Ultimately, what we see is that people then are prepared when trauma happens, when disability happens. Last year, my wife was diagnosed with breast cancer, right? She this was two-time cancer survivor. She had thyroid cancer when she was a kid. She got breast cancer last year, caught it early, double mastectomy, double reconstruction. And what she complained about was her pull-ups went down, after 8 to 10 weeks when we started working on our strict pull-ups. Never getting her range of motion back was a problem. Never managing the swelling, the other things, because we had some basics covered, and she's obviously married to a brilliant, handsome physical therapist, right? The key here was that I want everyone to appreciate that trauma is going to happen. Pathology is going to happen. Osteosarcomas happen. You get hit by a car. You're going to fall on the ice. It's okay. Let's be as durable as we can. And let's go ahead and pin this over to say that you already speak this language of nutrition, of sleep, of moving, and that when you initiate a conversation with your physician, he or she will be really clear and really grateful because, they were literally like, oh, you're set. I know what you're going to cover because I came in being able to speak to my body. And I want to shift more. I want to shift blame off our physicians. I want to stop physician blaming. Like physicians, we have their own patriarchy, weird stuff going on, reimbursement, et cetera, et cetera. But I always say to my patients, how prepared were you to use your physician wisely? And were you using your physician wisely? You went and saw your doctor for your knee pain running. That's like taking your cat to the car mechanic. You know what I mean? Like, she didn't get a chance to watch you run. She didn't just know your nutrition, your lifestyle, your history. She didn't even check your range of motion. She said, well, I can give you something to get out of pain because that's what I can do in this 6 to 8 minutes. So what we need to do is think differently about who owns health, who owns range of motion, and where we begin to have that conversation. I got a DEXA scan with one of my coaches a few years ago, and they were like, I think it maxed out at like 16 or 17 on the chart, and I was like 35. And they were like, what's up? And I was like, well, obviously, you don't measure human beings. Because I'm just some middle-aged guy who deadlifts a little bit and swings some kettlebells. Like, that's the difference between my bone density and these other things. So what I think we're going to have a much greater conversation. And then you are more durable for that recovery. And that your physician you're not tasking your physician with an untenable request, which is make me whole again. I have no responsibility. And our physicians are in such a good position. Our physios are in such a good position to be allies on the other side. But if your physician, the number of physicians we have in our gyms through the roof, right? Juliet went in for her 1-year checkup after a total hip replacement. And she's like, I did a Spartan race, I did 5. I won a world championship in whitewater paddling, And our physician, who's brilliant, was like, what the hell? We're the same age. You just schooled me and I have 2 normal hips. So he started training with us. Yeah. Right? And so that's how we need to have this conversation, and we can do it group by group by group, discussion by discussion, and give people better solutions. And if we give people better solutions, they will act on it or not as their free will. They will have better outcomes or not as a choice. But we've got to give people that choice.
Yeah, for sure, for sure. Now, so let me ask you something. Now that you've had an arthroplasty, have you changed your training at all to accommodate?
Oh, yeah. Right now, massively. So, I'm still, just at that 6-week mark. So I tell people from 4 to 6 weeks, man, the cake is just setting. Don't touch the cake. Don't bump the cake. Be cool, honey bunny. Right? Let's just get a minimum load. But now it's time to start to progressively just open up a little bit more. I'm not going balls out. I haven't ridden my bike. I don't want to fall and dislodge this thing. But what I had already done was remove a lot of movements that I couldn't tolerate because the joint couldn't tolerate shear. And what's going to be interesting is actually I get to put things back on the table that I haven't had for a minute. Like getting in a lunge shape, loaded lunge. I don't do that. Like, no way I could do that before. It was like a grindy, hot mess back there. It was like just, nails on a chalkboard. And so now what's really fun is I get to re-explore these positions. And what I will do is say, hey, look, this thing has a poly insert that will wear out one day, and I'm going to choose to use my credits on the things I really care about. So will I run some hills? Damn right I'll run some hills, but I'll do 10 or 12 short 80-meter hill repeats or 40-meter hill repeats, and I'll be like, ran, check the box. If my soul is engaged in marathon or half marathoning, that's going to be between me and my knee, and I will wear that poly insert out sooner than someone else. Will I be doing power cleans? Yes. And muscle cleans? Yes. Will I be getting stapled under a 375 full clean anymore? No. What I'll do is modulate my speed,
Yeah.
right? And save my credits for things like mountain biking, stand-up paddling, skiing, cross-country skiing, hiking. You know, what I want people to appreciate is not all movements are the same. And just like when people come to me, because we, you know, again, own a gym, people come to us and I'm like, hey, look, not every movement that we have is appropriate for you. My mother-in-law does not snatch. She does not full snatch, right? She muscle snatches a dumbbell. She does not, full snatch or power snatch a barbell. She muscle snatches a dumbbell. We still have snatches in there. They're a little bit slower, so she can arrive at end range. And what I want to appreciate for everyone is that, look, again, just because maybe we have 150 things we can do, 100 of them will still allow me to have elite level performance, get a ton of capacity out of my knee, and be durable. And again, I'll spend my poly credits where I want them, not wasting time in the gym training things.
Mm-hmm, mm-hmm. So
let me add one more thing. So you may see things that look more like back squat for me than front squat for me. Why? Because there's less shear across that poly plate. And I can keep my shin a little more. I don't have an ACL anymore. So I'm going to have to use my hamstrings. And so instead of slamming my knees forward, because I used to be able to do that, you'll see something that looks a little bit more like forward motion with the torso, a little bit more upright shin, things that look like a trap bar deadlift. That was what my squatting pattern will default to for strength.
Okay. So given your expertise and your knowledge, both in physiotherapy, but also as a strength and conditioning coach, your physician, your surgeon, did he say, oh my God, like this stuff you're going to do is crazy? Did he give you any restrictions, or did he just say, have at it?
What's interesting is that there's no guideline for him. There's no guideline for you. So is that guideline based on a 60-year-old with fragile bones? Is that guideline based on a 47-year-old with good hamstring control? Right? So lost you. Can you still hear me?
Yeah, I can hear you.
You just went full Matrix Neo.
Yeah, I don't know what's going on with my picture, but I can hear you still.
All right. So, one of the keys here is, we had this discussion about what's appropriate and what's not appropriate based on, was I a candidate for a hemi or a unilateral versus a total? And the conversation we had is saying, look, my job is going to require me to move and to jump and land and to handle some larger loads. And so I'm afraid that I'm going to shear through and destroy the implant. So the implant we chose together was an attuned knee, which was cemented in place because the thinking was, based on my strength and what I do and what I like to play, we should go for the most stable, bomb-proof, tested joint we can. And I'm grateful that that was the choice we made based on my lifestyle, right? And I'm not saying that that's the right choice for everyone, but that was the choice. So now the question is, for me, is what is strong enough? What's appropriate enough? Am I going to chase 600-pound deadlifts anymore? No way. Not necessary.
Yeah.
And no one knows. We don't know if that's going to handle it or not. What's the impulse load? What's the tissue tolerance there? Impossible to say. But what I can say is I'm going to give myself the fighting best shot to be as strong as I can in safe positions, and which means I have to slow down. I have to, that speed load component is a big deal in terms of shear force on the joint. And if I'm going slower and standing back up, I will be able to protect that. So a little bit of this is unknown. And if you look out there, there's only a few people who sort of have high function on total knees on the internet. And what we see is that it's really unknown because, again, the kinds of people who are having these surgeries are typically older, detrained people.
Yeah, yeah. So here's a personal question about the total knee. So I'm assuming that you probably had a cruciate retaining. In other words, it kept your PCL. ACL is gone, but it kept the PCL. And the reason why I'm assuming that is just because that kind of gives you a more natural feel and would allow you to do some more pivoting. So the question is, though, how does your new knee or your arthroplasty knee feel relative to what you had before? How natural does it feel to you?
That's a great question. And right now, what I would say is I have pretty good interoception and interoception about what's happening. And I can feel the altered fascial strains. I can feel that my quadriceps works differently. I can tell that he removed my fat pad and my patella is larger or has a greater volume than before, right? I can tell those things, or I think I can. I can tell that my MCL is a little tight, right? In flexion. I can feel that. So what I'll say is, having been, a national team athlete, having been, coaching and teaching for a long time, I have a lot of good awareness of my body and my position. And right now, my right knee does not feel like my left knee at all. But every day, my brain is starting to get used to new mechanics, new inputs. And what I'll say is I can already tell that I'm more force tolerant through that knee, that I'm already picking up better ground force reactions through the knee. Will I be a world champion tennis player again? Likely not from the cutting, but that's okay. I will be able to stand up, paddle, and do the things I want to do, right? So I think that's, for me, if I can get back too close to the way my other knee feels, and I think that's my responsibility, I feel like my brain will pick it up enough. I have, probably 10 degrees or 7 degrees of terminal knee extension, right? -7 on my other leg, as in I can, actually hyperextend my knee a little bit through the screw hole mechanism. I'm at 0 on this side, and I can tell that that's different in terms of how I lock my quadriceps up or go downstairs. So some of those things are different. I think it's too early to tell. But again, the things that were beginning to come off the table for me are going back on the table, and I'll take that trade-off.
Mm-hmm, mm-hmm. So do you think now that when you consider your personal experience and what you know of patients in the past, looking forward to the future, do you think that your personal experience is going to make you more, less, or the same level of aggressivity, if we use that word, with respect to your rehabilitative approach with patients?
Well, when I say aggressive, so nothing has really changed in terms of my actual approach to rehab, in terms of how we load, when we load, the kinds of loading we do. I think I will put forward even more sort of, we'll call it non-threatening or just input, somatosensory input, more balance, more vestibular work. I think early on as a young physio, you're like, strength is everything, right? Let's get you strong again. And now I'm like, you don't have control in space in that thing. Like, what are our mechanisms to give you your knee back to your brain, right?
Yeah.
So a little bit more focus on that, which is really easy to do. It's play. There's this thing I have called a slack block. And it's basically made by our friends at Slackbo. It's basically like a slack line that you can have in your kitchen. So it's a hard wooden plate on a really cleverly sculpted piece of foam. And I spend all the time on that thing. I'm probably on that thing 20 minutes a day on my right leg, working on my balance, ankle control, ball of my foot, right? And so what I will do is force people, again, at home, because they can't see me 5 days a week. That doesn't happen. They can't see, So, I worked as a young physio at Kaiser when I first got out of school and towards the end of school. And one of the things that I saw was, man, it took sometimes people 3 to 6 weeks to get in for an evaluation. Then they couldn't get a follow-up for 2 weeks, right? For a 30-minute follow-up. So what I realized was that a lot of the assumptions we make about the proximity and the amount of input the physio is going to have or time with the physio is going to be wrong. So I better really think about empowering people to take care of themselves at home. What are they going to do at home? What are they going to do for themselves? So setting up their environment, and my doctor work ended up actually being barriers to adherence. So what keeps people from doing what they need to do? Well, if I can set up their environment so that their Normatec is right by the bed, so they can pump when they're at work, so that they make their coffee and they can work on their balance, and then I can carve out a little bit of dedicated movement cardiorespiratory training in there, then that's a really sustainable model for people making progress. So the things I would change again are massively, more input, and then way more emphasis on soft tissue sort of regulation after surgery. I've been working with H-Wave for almost a decade now. I've been on the Normatec boots, but I think I'm going to be like, you need to document this for me. I don't believe you. I need to see what your numbers are on your machine. Otherwise,
show me the money. Show me the
money.
money.
Oh man, I don't believe anyone anymore. I'm like, look, if you have a surgery, I need you to get a sleep tracker, because you're going to show up with crappy recovery, or show up at your appointment, and I'm going to be like, well, you're not healing the way I think you can heal. Let me see your sleep. I'm like, you're not sleeping. You're watching Netflix and smoking the weed and drinking too much alcohol to self-soothe. I got it. So, those are the things that I think I've become a little bit less tolerant and more aggressive.
Okay. So I'm keeping an eye on the time here because Instagram gives us an hour. So I'm going to wrap up here. But let me ask you, just talked a little bit about this, but if you were to give somebody general recommendations, so if you're, let's talk about the active person, okay? So who has to have an arthroplasty, what are your general recommendations for that person? And I'm not talking necessarily a strength coach person, but just somebody who's active, they're in reasonable shape. What are your recommendations to them that are going to help them to maximize the result?
Prior to your time spent with your surgeon in this intimate COVID, he was in a bubble suit, and my wife dropped me off at the day spa. You need to max out on the things you can do. I need you as strong and as insulin sensitive and as vascular as we can manage. So if all you can do is bike, great, that's what we're going to do. If all you can do is, some quarter squat holding on, that's what we're going to do. So I want to max out. I want to get ahead of a nutrition plan. I want you to set some goals and really think, hey, I've got to go in with the machine running hot, not swollen and irritated, but I just want to be prepped so that my physician has the best tools to work with. And then I need you to really have a plan to manage your congestion. And that may mean compression and elevation, but 30 ankle pumps an hour is not going to do shit. That is to prevent you from having a DVT. That is not to, dump your lymphatic system. So I think we have to give people, I want someone to have an NMES device. And look, if insurance will pay for an icing machine, it will pay for a device that has better outcomes and gives you pain management. Because if you have less swelling, then you're going to have less pain. And if you have less pain, you're going to sleep better and heal better, and you're going to get your quads back, and you'll start moving more. And, sometimes I'm like, what are we even talking about? Because we're just assuming that people are managing their post-surgical insult, and they're not.
Yeah, for sure, man, for sure. So, again, I'm looking at the time, so I'm going to wrap it up there. But I'm going to call you back once we're done, just so we can finish up chatting here. But for everybody online here, in case they don't know where to find you and what you do, please tell them where they can locate you and, whatever it is that you want them to know about what you are doing.
Well, first of all, thank you so much for having this conversation. So great to kind of do the deep nerd. We are at the Ready State, and our site is, we have a free 2-week membership. You can come in and try to take a crack at self-soothing and pain management. We can talk about improving your mechanics. We can talk about downregulation and just soft tissue recovery. It's all in there at the Ready State. And if you go onto the socials or the YouTube, the Ready State, I probably make 25 pieces of content about my knee, long format, conversations, how I think about cupping, why I'm doing this. And you can really see I've been trying to be as transparent as I can about my own recovery and experience with surgery so that we can sort of lift the ball a little bit. So go ahead and check us out, and you'll see. And that's, again, how you and I connected, because you can see I'm really trying to say, here's my experience as a physio, knowing as much as I do about getting myself back into my own life as fast as I can.
Perfect. So thank you very much, Kelly. I greatly appreciate you doing this with me, man. This has been an awesome conversation, and I know that there has been a whack ton of useful information for everybody that has been listening, and for all the people who will put this out on social media too later. I know that they'll be greatly appreciative. As always, that's been a word from Dr. Chris, not your everyday ortho, and today, the Supple Leopard, Kelly Starrett. So I'm going to end it there. I will call you back in a few minutes on IG, so hang tight. All right. And
Cheers.
thanks everybody for watching who came out. I greatly appreciate it. See you next time.
Thanks, Doc.
All right.